In this video, we will discuss about Huntington's disease or Huntington's chorea. Huntington's disease is a hereditary disease that causes degeneration in the cerebral cortex and basal ganglia. The surface of the cerebrum is called the cerebral cortex, consists of a thin layer of gray matter. Masses of gray matter called basal nuclei or sometimes called basal ganglia lie deep within the cerebrum. These stretches play a role in the control of movement. Because of the degeneration of the cerebral cortex and ganglia leads to chronic progressive chorea and mental deterioration that ends in dementia. Huntington disease is a rare hereditary disorder that is characterized by progressive dementia and choreiform movements, uncontrollable, rapid, jerky movements in the limbs, trunk, and facial muscles. Causes are hereditary disease transmitted by an autosomal-dominant trait by conception. It is transmitted as an autosomal-dominant genetic disorder. Therefore, each child of a parent with Huntington disease has a 50% risk of inheriting the illness. Onset usually occurs between 35 and 45 years of age. Pathophysiology. The basic pathology involves premature death of cells in the striatum, caudate, and putamen of the basal ganglia, the region deep within the brain that is involved in the control of movement. Cells are also lost in the cerebral cortex, the region of the brain associated with thinking, memory, perception, judgment, and behavior, and in the cerebellum, the area that coordinates voluntary muscle activity. Why the protein destroys only certain brain cells is unknown, but several theories have been proposed to explain the phenomenon. One possible theory is that glutamine, a building block of protein, abnormally collects in the cell nucleus, causing cell death. Signs and symptoms. The most prominent clinical features are abnormal involuntary movements, that is chorea, intellectual decline, and often emotional disturbances. Severe choreic movements are involuntary, rapid, usually violent, and purposeless movements, initially unilateral and more permanent in the face and arms than in the legs. Constant writhing, twisting, and uncontrollable movements of the entire body occur as the disease progresses. Facial movements produce tics and grimaces. Loss of musculoskeletal control, gait becomes disorganized and ambulation is eventually impossible. Patient is eventually confined to a wheelchair. Speech becomes slurred, hesitant, often explosive, and then eventually unintelligible. Chewing and swallowing are difficult, and aspiration and choking are expected in such patients. Gradual decline, typically about 15 years of cognitive and neuromuscular symptoms, characterized by progressive dementia and choreiform movements in the limbs, trunk, and facial muscles are seen in this patient. Patients usually die from complications of impaired mobility. Dementia typically mild at first and then growing more severe until it disrupts the personality. Progressive intellectual impairment occurs with eventual dementia. Personality changes may result in nervous, irritable, or impatient behaviors. During the early stages of illness, uncontrollable fits of anger, profound, often suicidal depression, apathy, anxiety, psychosis, or euphoria are present. Hallucinations, delusions, and paranoid thinking may precede appearance of disjointed movements. Bowel and bladder control may be lost in this patient. Patient may die in 10 to 20 years from heart failure, pneumonia, or infection, or as a result of a fall or choking. Diagnostic evaluations. Diagnosis is made based on the clinical presentation of characteristic symptoms, a positive family history, the non-presence of a genetic marker, and exclusion of other causes. A genetic marker for Huntington disease has been located. It offers no hope of cure or even specific determination of onset. CT scan or MRI scans show symmetrical striatal atrophy before motor symptoms appear. PET scan and deoxyribonucleic acid analysis can detect Huntington's disease. The full form of PET scan is positron emission tomography scan. The treatment for Huntington's disease. Huntington's disease has no known cure. No treatment stops or reverses the process. Palliative care is given. Therefore, treatment focuses on supporting and protecting the patient, treating symptoms, and providing emotional support to the patient and his family. Safety measures to prevent injury or falls, supportive care, behavior management, activity of daily living and mobility assistance as needed based on stage. Thiothiazine hydrochloride, Navane, and haloperidol, Haldol, which predominantly block dopamine receptors, improve the chorea in many patients. Anti-Parkinson's medications such as levodopa, larodopa may provide temporary benefit to patients who present with rigidity. Motor signs are continually assessed and evaluated. Akathisia, that is motor restlessness, in the over-medicated patient is dangerous and should be reported. Psychotherapy aimed at allaying anxiety and reducing stress may be beneficial. Antidepressants are given for depression or suicidal ideation. Psychotic symptoms usually respond to antipsychotic medications. Patients' needs and capabilities are the focus of treatment. Nursing interventions for the patient with Huntington disease. Teach patient and family about medications, including signs indicating need for change in dosage or medication. Address strategies to manage symptoms like chorea, swallowing problems, ambulation problems, or altered bowel or bladder function. Arrange for consultation with a speech therapist if needed. Provide supportive care as Huntington's exacts or impose enormous or huge emotional, physical, social, and financial tolls on every member of the patient's family. Emphasize the need for regular follow-up. Refer for home care nursing assistance, respite care, daycare centers, and eventually skilled long-term care to assist patient and family to cope up with the situation.